Hi everyone, myself Dr. Vijaykumar M, Associate Professor from Department of Pedodontics and Preventive Dentistry, Vijaykumar Mission Shankaracharya Dental College, Ariyanur, Salem. Today my topic is pulpectomy. Pulpectomy, what is pulpectomy? Pulpectomy is which we can save the milk tooth. How we can save the tooth? That procedure is called as pulpectomy. It is similar to root canal treatment, what we do for adult. In adult, we do a root canal treatment. We can do a root filling and we can save the tooth. Similarly, we can save the primary tooth. That procedure is called as pulpectomy. Definition, according to Mathewson, in 1995, a complete removal of necrotic pulp tissue from the root canal of the primary teeth and filling them with an inert resorbable material to maintain a tooth in the dental arch. According to Finn, a removal of pulpal tissue from the tooth including both coronal and radicular portion. Justification, why we need to do pulpectomy? As I said earlier, removal of the diseased pulpal tissue and to maintain the tooth in its arch as a space maintainer, as a natural space maintainer. Objectives, following the treatment, what we will achieve? By doing the treatment, what we will achieve is the infection process should resolve. There should be radiographic evidence of successful filling without gross overextension or underfilling. The treatment should permit resorption of primary root structures at the appropriate time to permit normal eruption of the succionis tooth. No radiographic evidence of further breakdown of supporting tissues. Should prevent further pain and swelling. No internal or external resorption or other pathology. Indications, in which and all tooth we can do pulpectomy. Strategically important tooth, irreversible pulpitis, minimal periapical changes with sufficient bone support, at least 2/3 of the root length must be available, internal resorption without any obvious perforation. Contraindication, which and all tooth we need to avoid pulpectomy. That is extensively mobile and reduced bone support tooth, non-restorable tooth, internal resorption of the pulp chamber and root canal, underlying dentigerous or follicular cyst, pathology extending to developing permanent tooth bud, less than 2/3 of the root length remaining, perforation of the pulpal floor, medically compromised children. The procedure of the pulpectomy can be done in two types. One is single visit and other one is multiple visit. The procedure of pulpectomy is step 1. We need to give local anesthesia and isolate the tooth with rubber dam. Remove the caries and identify the exposure site. Remove the roof of the pulp chamber and identify the opening of the root canals. Step 4. Take a diagnostic radiograph working length. Clean out the root canals with H files and remove remnant of the pulp tissue and irrigate the canal. Step 6 is dry the root canal with pepper points. Select a lentillo spirals appropriate size. Mix zinc oxide eugenol as a slurry and spin it into the root canal using a spiral root canal filler. See, this one is a preoperative X-ray immediately after doing a pulpectomy. See, this is a pulpectomy done tooth where we can see the root canal is filled with a medicament and it is covered by a crown. Okay, and this you can see the periapical furcation radiolucency has been resolved. This is a 3rd month follow-up. We can see a reduction in the furcation radiolucency. Same, this X-ray shows a preoperative radiograph. After 6 months, you can see the reduction in the furcation radiolucency. As I said, there are two types of pulpectomy. One is single visit pulpectomy and other one is multi-visit pulpectomy. The single visit pulpectomy technique is first one, access opening for a pulpectomy in primary tooth. It is defined as the endodontic coronal preparation which enables the unobstructed access to the canal orifice, a straight line access to the apical foramen, complete authority over the enlarging instruments and to accommodate the filing technique. The ideal for endodontic access is complete removal of pulp chamber roof, removal of coronal pulp, straight line access to facilitate placement of endodontic instruments and obturating material. These ideals are balanced with following constraints: conservation of tooth structure, retention and aesthetics, and final restoration. The objectives is, we have three main objectives. First one is obtaining a straight line access to the apical foramen or to the initial curvature of the canal to aid in improved instrumentation control, improved obturation, decrease the incidence of procedural error. Second one is conservation of the tooth structure to minimize the weakening of the remaining tooth structure. Third one is de-roofing the pulp chamber and removal of the pulp ons to aid in locating the root canal orifice, maximum visibility, locate the canals, permit straight line preparation, prevent discoloration of the teeth due to pulpal remnants. To achieve optimal preparation, three factors of internal anatomy must be considered. One is size of the pulp chamber, second one shape of the pulp chamber, and third one is number, position and curvature of the root canals. Primary root canal anatomy. The clinician must have a thorough knowledge of the anatomy of the primary root canals and the variations that normally exist. As I said, the clinician must have a thorough knowledge of the anatomy of the primary root canal. Okay. In primary anteriors, maxillary incisors, the root canals are almost round but somewhat compressed. Normally one canal without a bifurcation. Accessory canals are rare but do occur. In mandibular incisors, root canals are flattened on mesial and distal surface and sometimes grooved. Two canals are seen in less than 10% of cases. Lateral or accessory canals are rare. Maxillary and mandibular canal root canals are correspondent to the exterior root shape, a rounded triangle with the base towards the facial surface. The lumen of the canal is sometimes compressed in mesial and distal direction. Lateral and accessory canals are rare. In primary molars, normally have a same number of roots and position of the roots of the corresponding to the permanent molars. It will be same as like a permanent molar. The roots of the primary molars are long, slender compared with the crown length and width. The divergence to allow for a permanent tooth bud formation. In maxillary, first primary molar, 3 roots will be there, 2 facial and 1 palatal roots. Palatal roots is often round and longer than the 2 facial roots. 2 to 4 canals are there. Bifurcation of mesiofacial roots into 2 canals, 75% of cases. Maxillary, second primary molar, 3 roots, 2 facial, 1 palatal, 2 to 5 canals. Mesiofacial roots usually bifurcates or contain 2 canals in 85 to 95% of cases. Mandibular, first primary molar, 2 roots, 1 mesial and 1 distal. Usually have 3 canals but may have 2 to 4 canals. Mesial root contains 2 canals, 75%. Distal root contains more than 1 canal, 25%. Mandibular second primary molar, 2 roots, 1 mesial, 1 distal. Usually have 3 canals but may have 2 to 5 canals. Mesial root has 2 canals in 85% of cases. Distal root contains more than 1 canals in 25% of cases. Second one, first we saw the anatomy of the roots. Okay. Second one comes the canal cleaning and shaping. Using local anesthesia and rubber dam placement, all accessible radicular pulp is removed. Relative to pulpectomy, due to tortuous course of root canal coupled with numerous accessory canals, complete removal of pulp in the primary teeth may often be difficult, if not impossible, that all procedures regarded as partial pulpectomy procedure. Selective filing. Resorption in primary teeth may have started at the time of treatment. Also, the slender roots with the thin apical ends and predispose the tooth to root fracture. In case of excessive preparation, thus procedure of selective filing should be used with an endodontic file. Remove the diseased pulp tissue from all the canals. The canal should be instrumented to be resistant point. Each canal should be enlarged 3 to 4 instrument size greater than the first file, capable of working the apex. It is not necessary to take an X-ray to determine the file length as done in permanent teeth. Visual comparison of file and root canal length on the pre-operative periapical radiograph will result in sufficient clinical accuracy. In the primary tooth, attempts to mechanical preparation or circular apical 1/3 may result in lateral perforation of the canal because of its hourglass appearance. Because of the anatomy of the primary root canal, the use of barbed broach as in conventional endodontics may be unsuccessful. Also, the ribbon shape of the root canals with a narrow mesiodistal width compared to their buccolingual dimension discourage a gross enlargement of the canals. Headstrom files are recommended since they remove the hard tissue only withdrawal, which prevents pushing infection through the apexes. For this reason, the reamers are not recommended. Instrument used in conjunction with an irrigation solution reduce the possibility of fracture because of the lubrication action of the solution. 5% sodium hypochlorite has an excellent solvent action and it's diluted enough to cause an only mild irritation when contacting the periapical tissue. After filing, the canals should be irrigated and then dried with cotton pellet or pepper points. Fillings of the primary root canals. See, the primary root canals has to be filled with a medicament. The ideal requirements of obturating material are as follows. It should be antiseptic, resorbable, harmless to the adjacent tooth germs, radio opaque, non-impinging on erupting permanent tooth, easily inserted, easily removed, should not stink, insoluble in water, should not discolor the tooth. This multiple visit pulpectomy. How the multiple visit pulpectomy is done? This procedure is used for non-vital primary tooth. It is studied by which in 1956, Lawrence 1966, Gold in 1972. It is in a short-term study and by Starkey in 1973 over a long term. The clinical technique is similar to the single visit pulpectomy. Both clinical technique is similar for single visit and multiple visit. In local anesthesia, rubber dam placement are recommended. In case of swelling and cellulitis is there, it can be omitted. Instrumentation of the canal is not recommended at the first visit. Since if the tooth is mobile tooth, swelling or fistula is present, if pus is present in the canal, instrumentation of the canal is not recommended. In absence of signs and symptoms, instrumentation can be proceed. Between and after the instrumentation, canals are irrigated. Between the appointments, antibacterial drug is sealed in the pulp chamber, maintained within a temporary cement. In some cases, the degree of preoperative cellulitis will indicate that drainage will have to be established. A smooth broach is used to perforate the apex and the tooth left open to drain not more than 1 day. If kept open for more than 1 day, usually results in a food packing into the canals. Systemic antibiotic therapy is also indicated. External heat should not apply as it may result in extraoral drainage of the infection. In these cases, the coronal pulp chamber can be filled with beechwood cresol soaked in a cotton pellet after 24 hours of drainage. Appointments are 7 to 10 days apart. The numbers of appointments and timings and extent of the instrumentation will be determined by the signs and symptoms of at each visit. The canal should not filled until they are dry and all other signs and symptoms have been eliminated. Follow up of the pulpectomy. The tooth should be restored with the final restoration with stainless steel crown. This is the stainless steel crown. The ideal restoration for an endodontically treated primary tooth is stainless steel crown, but in some cases it may be acceptable to delay the crown, leave the tooth with an amalgam restoration. How will you assessment the success? The post-operative follow-up of 6-month interval should include an evaluation of signs and symptoms. Evidence of failure, when we call it as failure, clinically pathological mobility, the tooth should have a mobility, presence of fistula, pain on percussion. In radiographically, increased size of radiolucency, external or internal root resorption. This is considered as a failure. Criteria for an ideal pulpectomy obturating material, as already we seen, antiseptic, it should be resorbable, harmless to the adjacent tooth germ, radio opaque, non-impinging on erupting permanent tooth, easily inserted, easily removed, should not stink, insoluble in water, should not discolor the teeth. What are the obturating materials? What materials is we can use? First one is zinc oxide eugenol. It's most commonly used. Its disadvantages are overfilling causes foreign body reaction, difference in rate of resorption from that of tooth root. It has a delayed resorption. It will resorb very late. Okay, so that the retention of the material will be there. The success rate is 65%. Then iodoform paste. It is a composition of iodine derivatives. Advantages: resorbs rapidly. Extruded paste in the periapical tissue is replaced with normal tissue. It is bactericidal, can be removed if any retreatment is required. Success rate is 84%. KRI paste. Its composition is iodoform, camphor, parachlorophenol and menthol. Then calcium hydroxide. Calcium hydroxide is not used in primary tooth pulp therapy. Calcium hydroxide with iodoform paste mixture is a good material of choice in pulpectomy tooth. Vitapex. Vitapex, it is in a composition of, as I said, calcium hydroxide with iodoform. The properties are non-toxic, easily apply, resorbs slightly faster than the rate of the root, radio opaque, 100% success rate with this material. Then endofloss. It is in a composition of zinc oxide eugenol, zinc oxide, barium sulfate, iodoform, calcium hydroxide and eugenol and pentachlorophenol. The properties: micro leakage in prevented and 70% of success rate. Gattapercha. Gattapercha is not indicated in primary teeth since it has doesn't have the resorbable property. It is contraindicated in primary tooth. So don't use gattapercha in primary tooth. But in one scenario we can use where we can see congenitally missing permanent tooth. Congenitally missing permanent tooth, if we want to restore the primary tooth, we can use gattapercha. But in normal cases, gattapercha is contraindicated. No materials currently available meets all the criteria, but commonly used materials are zinc oxide eugenol and calcium hydroxide with iodoform paste. The obturating technique. How will you place the obturating material into the canals? This is obturating technique. Endodontic pressure syringe. These apparatus consist of syringe barrel, thread and needle. Needle is withdraw 3 mm with each quarter turn of the screw until the canal is visibly filled at the orifice. The endodontic pressure syringe is also effective for placing the ZOE, that is zinc oxide eugenol, into the canals. The Vitapex system is also used in the syringe with the material. The syringe is introduced into the 1/5 distance from the apex of the canal and the material is slowly injected and the material is placed into the canal and it is slowly, the syringe is slowly withdrawal. The mechanical syringe, the second one is the mechanical syringe. The cement is loaded into the syringe, normal syringe with a 30 gauge needle as per the manufacturer is recommended and it is expressed into the canal. Press using continuous pressure while withdrawing the needle. Then comes lenticulospiral. Paste can be filled by means of lenticulospiral mounted on a micromotor handpiece. The direction of rotation needed to be checked for a material to properly flow into the canal. Increment filling. Endodontic plugger corresponding to the size of the canal with the rubber stopper is used to place a thick mix of cement into the canal. The thick mix was prepared into a flame shaped corresponding to the size of the shape of the canal and then tapped gently into the apical area with the help of the plugger. The primary teeth with the larger canals may be filled with a thin mix coating on the walls of the root canals with the help of the reamer in an anti-clockwise direction while taking it slowly, followed by placement of thicker mix of material then pushed manually. The other techniques are amalgam plugger, then paper points, then plunging action with wet cotton pellet. Thanks for watching. Thanks for listening to my classes. Thank you.